I'm here with Dee Stephenson. Dee, I'm so happy that you're here. You know, I'm excited because our OR is going to be getting an intraoperative aberrometer. I've heard from other cataract surgeons that they're making real surgical changes based upon the data that they're getting. You know, I use toric calculators currently, and the results that I've gotten are good. I can't say that every single patient's absolutely perfect, and I wonder how much of an impact an aberrometer is going to make if I already have these calculators. Now, I know you're the person to ask because you speak on this subject. Can I get you to kind of flesh out what the issues are for me?
Sure. Well, you know, with toric lenses, patients are really demanding now, and they want the current toric lenses on the market. Give you monofocal vision if you correct the astigmatism, but they don't give you much else. So I have been using a new toric lens, the True Line, which gives you a broader range of vision. But more importantly, I believe that, all the calculators, anything that gives us information preoperatively is always helpful, or hopefully always helpful. Sometimes the waters get muddied because different tried and true things don't match up. When you look at, just information that you get from an A-scan and a topographer, you get the magnitude of astigmatism, you get, the axis of astigmatism, and it can vary in those tried and true instrumentation. But with Aura, it does something much more special, which is, Dr. Cook talks about this all the time, but it measures not only does it measure magnitude of astigmatism, axis of astigmatism, but it measures posterior corneal astigmatism. And I believe that that is more important than we all have believed in the past. Now we know we undercorrect against the rule of astigmatism and we overcorrect with the rule of astigmatism. So Aura with VerifEye has allowed me to really hone in on the things that are important to me. Number one thing is pleasing a patient when they come in for a premium procedure, that you can get your target without having to go back for a re-op or a post LASIK or PRK. Sure. So I'm not a LASIK surgeon, so I had to find something in my armamentarium that would raise the bar for me, and Aura has been that for me.
Now, Dee, I've tried out intraoperative aberrometers on the show floor. They're a lot of fun. Let me ask, in terms of what the flow is like in the OR. What's it? Kind of talk me through it.
Okay. Well, first of all, remember that there isn't, what you're looking at are not intraoperative aberrometry. You're looking at an overlay or something that goes on top of the cornea. You're not actually measuring, it's a static measurement that you're looking at. What a Aura, or the intraoperative aberrometry, is, it's actually an intraocular reading. It's a SLED, a type of diode, and it's on your microscope. Okay, it comes down about 3 inches. Some people have a little bit of trouble adapting to not having as much space to do surgery, so they hit their instruments. But it's basically an aberrometer that goes on any microscope, and what it does is it measures, we all have learned that measuring the eye in the aphakic state allows you to get the most precise measurement. So Aura actually takes, 40 readings, and it's intraoperative, but you've got to raise the pressure, okay, to 21 to 22 millimeters of mercury with viscoelastic or BSS, and you have to actually measure it. Okay, you've got to make sure your fornices are clear of viscoelastic, and you've got to make sure that your cornea is nice and clear. So there are some, the lid speculum's not pressing on it. So there are some things that you have to do, like a cookbook. You have to do that. If you don't measure the pressure, that's the most important thing. If you notice, you could lower the pressure, and you could watch the aberrometer, change the amount of cylinder and the axis. You raise it to 22 millimeters of mercury, and if you raise it a little bit more, it only gets it doesn't change a whole lot. So the lower pressures, it changes a lot. But adapting to this, putting this on your microscope and taking measurements, at the beginning for me, I was way back in the days when it first came out, it was called orange or lemon, as some folks have called it in the past. But now it's so quick. It adds about 2 minutes to my surgical day per case. And, for me, that's not a lot because my deal is outcomes. But for some high volume that do 50 to 100, 2 minutes a case adds up to more time sometimes than they would like to spend. But for me, the outcomes have enabled me to not have to do touch-ups, to send them somewhere for PRK or LASIK. no IOL changes.
So you get those couple minutes back later on.
Yes, you absolutely in tenfold, and it's much more cost effective to do it that on the front end as opposed to the back end, as we all know.
Now, you brought us some very nice slides. Let's get a look at them now.
Sure. For instance, if you look at this preoperative cylinder characteristics, we're looking at the Atlas topographer and the IOL master. And this demonstrates one of the challenges of working with toric IOLs. This represents a summary of the corneal measurements this evaluation obtained with the tried and true instrumentation. The mean magnitudes, the axis of orientation, and ranges vary, which you can see. Which set of these measurements do you believe? You worry whether, do you believe all of these? Well, these are all great demonstrations of showing that there's also a value in aura as well. The instruments on this slide reflect the magnitude of astigmatism on the anterior surface of the cornea, and they do not measure the contribution of the posterior cornea. Aura's aphakic measurement does that. And if you look at this, I'll show you a video that captures what we're talking about. This is the real-time reading across the top in the blue light, in the blue letters. What I'm trying to do, the fringe patterns upper right, bottom right is showing the Purkinje images. So what we want to make sure is that the eye is pressurized to appropriate pressure, 22 millimeters of mercury. We have the patient stare at a little red light, 40 captures, takes about 2 seconds. Tells me to use a 19.5 diopter and with a +2 SIL. I should have negated most all of my astigmatism. Now this is a pseudophakic, so this is the toric package within aura.
You're checking pressure here.
I've checked pressure. That's what the little tonometer there is. Definitely checking pressure. And it tells me which way to move it. Do I move it counterclockwise or clockwise? Or is it where no rotation is? You've got good Purkinje images, so you know that the lens is not tilted. Measurement is taken, and it tells me no rotation. So I have a residual of 0.35 astigmatism at 1 degree. So that pretty much hit my target. And how many times do I change this? Well, so many times during surgery, I've changed the cylinder power in 39 of the 63 cases that I'm reporting here at this meeting, which is about 62% of the time. The interesting fact here is that 18 cases for the TrueLine calculator that I did on all patients preoperatively told me that I didn't need a toric lens, and yet Aura did. So of those 18 cases, 8 of them required a -1.25 diopter SIL, and 8 required a -2 diopter SIL, or a 2 diopter SIL, and 2 required a 275. So, that's pretty impressive. That's 18 people I would have made very unhappy had I not used Aura. So if you look at the distribution here for the refractive astigmatism, the TrueLine calculator did a pretty good job. 70% were within about a half a diopter, and 38% were within a quarter. But if you look at Aura, you see that brings that up even more. Aura mean cylinder was 0.09 plus or minus a quarter. 97% of the patients were at half a diopter or less, and 90% were at a quarter diopter left. So this is, to me, very powerful, a very, very powerful tool in the operating room to improve your outcomes.
So, Dee, you make a very powerful case here. I'm impressed with the number of times that you had to make changes, and that leads to a logistical question. When you go to the room, how many lenses do you bring with you?
Well, that's an interesting question, and you and my administrator asked the same question of me many times. I have a very supportive operating room, and I have pretty much access to anything. I'm very spoiled, anything I would like. But what I do is I pick usually a power 2 to one side and a power 2 to the other side of what the IOL master tells me. So
spherical power or cylinder power? Spherical
power and cylinder power. So I do use the TrueLine calculator. If they tell me to pick a +2, SIL, then I do pick that. But I do get each of those in +125, +2, and +275.
So I'm bringing 8-9 lenses to the room.
Yes, exactly. And if you have a good, amount of lenses,
Sure.
good range of lenses, usually you don't have problems. There are some limitations to the TrueLine currently because we don't have all the powers available. Under 17 or over 25, we don't, or 26, we don't have any yet. But it's really pretty much you start to learn a gestalt of it.
Yeah.
And the surprising thing to me always is when I go in thinking I have all this astigmatism and I have none, or very little, or I go in and I have no thinking I have no astigmatism. For instance, I prepare somebody to have a crystal lens, and they have no astigmatism, and I get in there and they've got a buck and a half of cell. Well, now the True Line allows me to take care of that, giving them the same field range of vision that they can have with a crystal lens itself. So it's really up to my game, but it is. You have to, everybody in the operating room and at your surgery center kind of has to be on board with that.
Sure, Dee, this is great stuff. I'm really glad that you brought it to us.
Well, thank you.
I'm very grateful for the time that you've spent with us today.
Thank you.